Hi, everyone. So I'm very happy to be here. Just a short introduction. I'm a research director, so researcher in statistical learning and applications at Inria, and I'm also very interested in having an impact beyond academia. So I'm investing a fair amount of my time in the probable startup that focuses on open source tools for machine learning. And so today I'd like to talk a bit about what I've learned in many years of being at the boundary with help. So some of our dreams and some of the challenges, and this will be between applications and more the machine learning concepts without too much math. So just to set the picture, the what I call statistical learning, which is just a view on machine learning on statistics, is really the fundamental framing of machine learning, where we're trying to predict one quantity, which could be one health outcome, for instance, as a function of others. So really, what we're trying to do here is trying to approximate an unknown function that links those two quantities. And in general, the simplified way that we're doing it is that we're optimizing a function or function parameters to minimize the sum of observed error between our predictions. So f of x, where x is my data, and our observations y. So that's really, we're just minimizing an observed error. Of course, it's slightly more complicated than this. And one of the challenges is that we actually have only a small amount of data that we have observed. I'm pushing here the challenge a bit. I've put a very small amount of data, but the thing is that this data comes in with noise. There's always noise in the data for all kind of reasons. And so if we really try to minimize too much the data, well, we're going to capture too much is the error, so we're going to capture this noise. So a statistical way of saying this is that we would be interested in minimizing an expected error, but in practice we have only a small amount of data, so we're minimizing a finite sample error, and this is going to be a challenge in machine learning all the time. So in practice, what does it give us is that if we, for instance, we fit very complex models, we have enough degrees of freedom, enough things to change in our model that we can perfectly fit the data, as I've shown here on the slide. But this perfect fit of the data, as I was mentioning just before, will capture noise. And so we have a perfect fit of the data, but a perfect fit of the data that has captured noise. So this is the notion of overfit, and one way of thinking about it is, well, the problem with it is that it doesn't generalize. So you give me new data comes in with different noise, and so this shows that this new data will reveal this overfit. It will reveal that our model is too complex for the data, and our model has captured noise rather than the signal. So we need to fit models that are complex enough to be as rich as possible, and simple enough to avoid capturing the noise. And here, the idea to have in mind is that we need to compare some conceptual notion of model complexity with the amount of data that we have. Okay, so that was just a very short introduction to some concepts in machine learning, and I want first to dig into what I've learned doing machine learning on health data for quite a few years, and what are the relevant questions and what's the relevant data, and then I'll show you some challenges that just keep popping up always and always and always. All right, so to start, with the kind of questions we might be interested in. Well, they're classic tasks in medicine, very, very common. Typically, One might think of diagnostic models, and here the goal is that we're given complex, potentially incomplete data, and the goal is to describe best the patient's status, typically by giving classic diagnostic labels, well-labeled pathologies. And we can also think about prognostic models, and here prognostic models, the goal is to predict future evolution. So one is a now costing task, and the other one is a forecasting task. And so your typical diagnostic task is that of medical imaging. And so computer science has been interested in medical imaging for a long time because this is a very complex data. It's high dimensional. You have structured individual variability. And the typical diagnostic task is to say, well, can I help the radiologist? So basically, can I do some form of automated reading of a complex image to save time from the radiologist or the overall health system? Typically, with medical imaging, most of the studies do not look at long-term outcomes. And I'll come back to this because in terms of health, it's very important to look at long-term outcomes, because what we really want is to have a system that gives us a long-term health. So from a health perspective, medical imaging is often useful in acute cases, but from a public health perspective, it's very often, too little, too late. What I've noticed working on medical imaging for many years is that we typically struggle with sample sizes. We have sample sizes on the around of on the orders of magnitude of say 1,000 individuals, and for machine learning, this is actually not a lot. It may seem a lot for medicine, but for machine learning, it's not a lot. And the reason is that basically a medical image is expensive. You don't acquire it just for the sake of it. And also you only see the broken people, at least typically in your typical practice. And it's the same reason. And so both, only seeing the broken people and having a small amount of data is definitely a challenge for machine learning. It's really a bottleneck. Another challenge is that, we're really limited when we do medical imaging. We're really limited by the data that we have. And, as a field, sometimes this pushes us to focus on what we have rather than what's clinically relevant. And one way to see this is that a few years ago, almost 10 years ago, there was a large data set of lung cancer that was available thanks to an online Kaggle challenge. And what this created is it created a jump in the publications on AI and lung cancer. And this is visible in the publication. So the AI lung cancer jump, but typically AI and breast cancer didn't jump because the data was the same. But that's in the AI literature, in the machine learning literature. Now, if you look in the medical literature, we don't have a sudden focus on lung cancer. And the reason, as far as I know, is that from a medical perspective, from a public health perspective, there hasn't been a change. There's no magic cure for lung cancer, and there is no bigger health burden of lung cancer. So this is just an illustration that often we tend to focus on the data we have rather than the data that's useful. Of course, by construction, there's not much that we can do here, but it's a challenge to keep in mind. Now, another challenge, which I think is extremely important, is that imaging is only a fraction of a patient's information. If you look in a natural health practice, a medical image is never used only by itself. It will always be combined with simple sociodemographics, but also typically a history, even if it's a short-term history of an individual's health status. And so what we find, what we found a few years ago is that in sometimes, cheaper data is more predictive of a health outcome than expensive, for instance, brain imaging data. And so, from a computer scientist aspect, we love complex medical images because they are complex. But from a health perspective, the question is, are they the most relevant data to use? And so this brought me to switch to electronic health records. So electronic health records are basically all the routine care and administrative data that a health system accumulates about individuals. So it's the biological exams that we might make, things like blood sample analysis, but it's also all the clinical information, including clinical text that is gathered on an individual as the individual goes through the system. It's also all the accounting and claims. That's very important because all the social security systems, all the insurance systems, all the hospital accounting systems gather data for accounting purposes. Accounting is important. This is how people balance the bill, and typically this data is well kept. So basically, it's everything in the hospital. And the promise here is that it's quote unquote free. It's already there. It's already in the hospital databases. Also, it has very good coverage. Anybody who goes through a given health system is in the database. So anybody who goes through a hospital is in the hospital health record. Anybody in France who has access to Social Security, which is currently pretty much everybody, at some point leaves traces in the Social Security system. So, it's a very exciting source of data from a machine learning and health perspective. So to give you an example, the kind of data I've worked on is the data of the Paris hospitals. It's a network of hospitals, 39 different hospitals that sees, almost 10 million individuals per year. So very, very rich data, as opposed to a medical imaging cohorts, more promising. So I got involved during the COVID outbreak, and basically we tried to help the hospital management system. And so the interesting thing is that the first questions we were asked were really questions to inform hospital level decisions. So COVID outbreak, there's a new outbreak of a new disease, and there's a changing reality on a day-to-day basis. And so the first question we were asked were, can we do a data-driven portrait of this changing reality? And then, the next question we were asked is, okay, well, once we have this, can you do forecasting? Can you help us plan what's going to happen tomorrow and the day after tomorrow? Because we need to allocate resources. We need to allocate human resources. Maybe we need to change our priorities. Maybe we need to stop planned intervention, planned surgery, because we need to free the resources, the human resources, the rooms for the COVID outbreak. So that's a forecasting problem. It's really, can we say what's the influx of patients that we're going to have tomorrow and the day after tomorrow and the day even after tomorrow? That was kind of the second task that we were given, and then only then we tried to go further, and we tried to basically understand the individuals. And so here the benefit was that the hospital was accumulating data on those individuals, and could we quote unquote mine? So could we extract information from all this data to give a portrait, an accumulated portrait of the individuals. And so the best source, by the way, was the claims. People were describing the pathologies that in the structured claims, and so we could analyze those structured claims. So these are ICD, so International Classification of Diseases codes. And so we could basically do a portrait of the comorbidities of COVID. And so in the very quickly we could see emerging things that are well known by now, which is that COVID is not only a respiratory disease, but that is a disease that will come in with cardiovascular challenges, but also that will be very associated with things like diabetes. Those are things that are well known these days, but we could see them very early on. And so immediately, we wanted to say, well, can we do more? Can we, for instance, predict important questions, such as, should we send a given individual to intensive care units? And so we did this. We took this data and we predicted does an individual goes to intensive care, and we could predict quite well. And we didn't bring much useful information to the clinicians, because we only taught them what they were doing. The clinicians were driving their medical decisions on a given analysis of the problem. And the only thing that we told them is that, well, we've understood your analysis. So absolutely useless from a medical decision perspective. Useful from a piloting perspective, because this was useful once again for being able to predict at the hospital level, how many intensive care unit beds are going to be used. But the thing is, we were not useful here for medical decisions, because when we captured, does an individual goes to intensive care unit or not, we captured the doctor's decision, whether they were optimal or not, and we were not bringing anything new to the doctors. I'll come back to this because this is important. So, first thing that keeps coming up in my experience of machine learning for health or for medicine is, having some humility from a machine learning perspective, because the clinicians and the health system has an expertise and knows what it's doing, and we're just assistants. We're not driving the system. It may seem obvious, but it's important to state it again. So that was just an example during the COVID crisis. Can we take a step back and, now we're no longer in a crisis mode, and can we do some more systematic analysis of, how we can process this data, and how we can build systems that process this data for different purposes, piloting, but maybe also prognosis. And so in the years after, we did a systematic study of what gives a good prognosis model. So what, from the data that we have here, what allows us to predict the future of individuals' health. And so we did this study on a small cohort extracted from the Paris Hospital's electronic health records. And the cohort is 200,000 individuals, and we're looking at the claims. So once again, the claims are the notes of all the acts that are performed on the individuals from a reimbursement perspective, from a billing perspective, insurance, for instance, but also the biological values, ranging from, for instance, blood pressure to blood sugar level pressure, and all kind of biological measures that are taken quite routinely in the hospitals, inflammatory markers and all this. And this is a prognostic study, so the question is, can we predict future evolution, future pathology? And here, how do you capture this in such a system? Well, typically you look at hospital readmission, because you're looking at hospital data. So if an individual comes back to the hospital, it's a signal on the individual's future health. And then also the question is, can we not only predict readmission, but can we predict the associated diagnostic? And the methodological question that we're asking here is, what's the best machine learning approach? If you talk to AI people, they will tell you, well, a deep learning model. If you talk to an epidemiologist, he will answer, well, a linear model. So which one's correct? So there's actually much more. There are many modeling choices. And the first challenge is that you're actually starting from a whole history of the individual. There's the past. It's not a given snapshot. So you need to build covariate. You need to build information from this history. And so you can choose to build this using only the demographics, so age, sex. We looked at what we call delay counting, which is how do we aggregate information? We basically look at all the information, but the information that's further away, we discount it. We multiply it by a factor that gives it less information, or exponentially weighted average for technical terms. We looked at using embeddings because you have many codes. An ICD diagnostic code is, the 50,000 different ICD codes. So can we embed them in a lower dimension space? And we looked at this with locally optimized embeddings or nationally optimized embeddings. So the embedding is a typical AI strategy. And on top of this representation, we looked at different predictors. We looked at linear models. So if you have a linear model for classification, you're going to be using a logistic regression. We looked at random forests, so tree-based models. And we also looked at the deep learning method, which can actually work directly from a sequence of event, so that we can apply on the whole patient history without doing the summarization. And this sequence model is based on transformers. Transformers are quite popular these days because they're behind the large language models like ChatGPT. And so what we're doing here is that we're really benchmarking a gradient of model from simple models, logistic regression, to very complex model, those transformer-based models. And so what predicts best? So here I'm showing you what predicts best as a function of the number of patients that we have in the train set. And it's higher is better. And what you can see is that what predicts best here is the random forest on the decay counting. The decay counting is this exponentially weighted moving average, basically, that we're doing. And so this is the best predictor. And it markedly outperforms, for instance, the transformer-based model, which is typically what AI people would do. So the most complex model. It also, by the way, outperforms markedly the logistic regression, which is typical epidemiological practice. So, by the way, maybe very expert feature engineering would improve the logistic regression here. It's also very challenging to do feature engineering in those electronic health records because the data is not the data of a typical clinical study, it's the data of routine care. Okay, so here the best model is the random forest, and it goes back to something I was saying in my introduction on machine learning. The best model is not always the most complex one. The best model is not always the simplest one. The best model is the model that is suited to the amount of data you have, to how rich your data is. This, by the way, this finding that here the best model is the tree-based model is a finding that we've seen elsewhere on other data. It's very typical of tabular data. Deep learning these days in AI is very popular, and we all do a lot of deep learning. But what we found is that for tabular data, for tables of numbers and categorical entries, tree-based models are very, very strong performers, and it's very hard to outperform them with deep learning. And the reason is that there are properties of the data, fundamental properties of the data, typically that each column is meaningful by itself. If I have a column that describes age, if I have a column that describes weight, those are columns that are meaningful by themselves. And the way a tree-based model works is by favoring decisions on the column level. So they're very suited to this data. They're also very suited to the fact that we have categorical features, men, women, but also diabetic, yes, no, type of diabetes in the data. Okay, so then the question is, okay, what if we had more data? Well, I can't tell for sure. We're still working on this. But if you extrapolate the curve, one model keeps going up faster than the others. It's the richest model. It's the transformer-based model, the AI model. And so currently it's an underperformer. But possibly if we have more data, it will catch up because it's more flexible. And if you have lots of data, it can capture the richness of the data. So, give me much bigger cohorts. Maybe the best predictor is going to be a more complex model. Now, why was this cohort so small? The numbers I'm showing you were numbers in the thousands, but I told you I started from a cohort that was 200,000. And so the reason is that the minute you ask a somewhat focused question, the number of data points that you have to answer this focused question drops. First problem, most patients don't have a lot of data. Most patients, on the time window that we have, most patients didn't come to the hospital twice. And so because what we're trying to predict is readmission if the patient comes back. Most patients did not come back, and that's good news. And in general, most pathologies have a small prevalence, especially the severe ones. That's also good news. So that's very typical of health data. Even if we start from the full French population, the minute we ask a precise question, we're going to have much, much smaller sample size. Okay, I've currently focused on claims because it's structured data. It's easy to use. But there's much more information in the system. The clinical notes. The clinical notes, so the notes are taken by the different people who work with the patients. They're extremely important because they contain a huge amount of information on the patients. Typically, they embed the context and the clinician's understanding. To simplify things, you have a clinician, the person who's an expert, who's taken time to look at an individual and who's written some notes on his or her understanding. Not capturing this is throwing away incredibly important information. Now, they're really challenging to work with. This is a typical this is a typical note. Now, it's in French, so you might not understand it. But what you'll see is that you have both a large amount of typos, and those typos are due to the process with which the note was input. If we had better computing system, we would have less typos. But you also have a lot of domain-specific abbreviations and jargon. So we need to capture this. It's not impossible, but it requires a lot of work. For this, deep learning and language models are crucial. So on a related study, what we've seen is that with fairly simple deep learning, but still deep learning, we're able to get a bump of accuracy from 0.7 to 0.75 AUC. That doesn't seem huge, but this kind of bump is really useful to have a more useful prediction. Okay, so to zoom out, there are different type of health data, and with a different type of health data, we're going to have different models. With medical imaging, my concern is really a concern of external validity. You can get high-quality images, but they don't match real-life practice. When you get real-life practice, you only have, quote-unquote, the broken individuals. With text, you're going to use pre-trained language models, and the challenge on a day-to-day basis is quality assurance of what you're doing. And with electronic health records, really the bottleneck is data preparation, is understanding all those accumulation of data and the biases that comes with. And in my experience, we're always in a data limited regimes. We're never in a huge amount of data, because even when we have many individuals, the data is very complicated, and any specific health question, gives us very little individuals. And I want to remind that we have different goals. One can be diagnostic or information extraction. Information extraction in electronic health record is a bit a form of diagnostic. So really here, the thing is, can we help the caregiver, or the health professional to work faster? If we're doing diagnostic from medical imaging, we're really trying to help the radiologist to work faster. And then there's the prognostic or future prediction problem. Can it be useful at the individual decision problem? And I'll come back to this. It's extremely challenging. It's easier to help resource management. So hospital piloting. I have a typo here. Now, over and over and over again, predictors fail to bring medical benefits. It's well documented. The question is why, and I'm not going to go into too much in the details, but one of the reasons is that the data we have typically only partly reflects the application. For instance, we could have in our data information that's consequence of the diagnostic. For instance, you're trying to do diagnostic from chest X-ray, and some of these X-rays have a chest drain, and you learn to predict that this is a pneumothorax, which is correct, because when people have a pneumothorax, then you add in a chest drain. That's absolutely of no use, because you're using information that the system already knows. Other problem, you have sampling bias. So basically, the data you're working with is not representative of your target population. So you're working from a research study from perfect images, but your clinical practice images are crappy. And so your predictor built on the research study doesn't transfer to your actual clinical data. So here I'd like to talk a bit about how we're going to bridge the data to the application. So I've already mentioned this. The data may not reflect the application. Sometimes you have a benign problem, a benign selection bias. Technically, it's known as covariate shift. So the idea is that, once again, we're trying to predict Y from covariates X, and the covariates X have changed, but the link from X to Y is preserved. So I have a sampling bias. And so what I'm showing you here is that if I have so here I have the source data, and I'm trying to transfer to the target data. And here you can see my source data is distributed. There's a sampling bias between my source data and my target data. And I'm trying to classify, to separate these dots from these dots. But the separation is the same. It's just a sampling change, a covariate shift. And what I can see is that a simple model doesn't transfer well. But if I have a complex model, it transfers well. So if I have a covariate shift, and if I have enough data in a complex model, the covariate shift is not a problem. Asymptotically, with complex models, the covariate shift is not a problem under a mild assumption. I can do slightly better, and I can use reweighting, and reweighting will help for simple models or limited data. So here what I've done is I know the shift between my source data and my target data, and I'm reweighting. So I'm, for instance, downweighting the individuals that I've never that I don't have in my target data, and updating the individuals that are underrepresented in my source data. And if I do this, you can see that now the simple model works also. So covariate shift is a real problem, but it's a problem that can be addressed if you have enough data and rich enough models. Now, other kind of selection bias will break the association. For instance, here, I'm showing you a selection bias where the data is selected not only on X, but also on Y. So my blue population is my full population, and my orange population is a subset of my full population. And you can see that here the association between X and Y has changed. This is a selection bias that distorts the association between X and Y. And it does this because it's due to a common cause. The selection is a common cause between X and Y. It's not a selection only on X, it's a selection on a common cause between X and Y. And when this happens, more data and bigger model will not solve the problem. It's not just a covariate shift, and it's not just a question of getting more data. You need to do more. You need to do specific modeling. This is, I believe, quite frequent in health data because typically in routine care data, you have a measure or you don't have a measure because of the mechanism, the health challenge that you're interested in. I have seen someone in the hospital because that person needed to go in the hospital. So it's a sampling bias from my general population. So let me expand a couple of common cases. The first very common case is censored data. So censored data, for instance, is the idea that some of the outcomes have not yet been observed. It's maybe the most classic biostatistical question. It's known as survival analysis. And so you're interested in evolution of individuals and you have an observation window. You have data between one start time and one end time. And for some individuals, you've seen the outcomes. And for some individuals, you haven't seen the outcomes because the outcomes haven't occurred before the end of the study. And a special case of this is what we call competing risk, which is there are multiple types of outcomes and you're interested in this. Now, you can do a naive outcome, which is to say, well, I'm just gonna drop all the individuals for whom I haven't seen the outcomes. Now, if these individuals are a large fraction of your data, a significant fraction of your data, you will bias your analysis. And so to give you an example, if I'm trying to find how much time individuals spend in intensive care units, and most of my individuals have entered the intensive care unit less than a week ago because there was a very large outbreak and most people have just come in the intensive care units. And I drop the people that didn't come out of the intensive care units. By construction, when I do this, I'm keeping only the mild cases that come out really fast. I'm ignoring all the severe cases, and my conclusion severely underestimates how long people spend in the intensive care units. All right, so one way of solving this problem when you're doing machine learning is to compensate for this bias and to compute the probability of censoring. So that probability increases with time, because the longer the individual trajectory, the more likely you have to it is to have been interrupted. And so you compute the probability of censoring, and then you take the individuals for whom you have seen the outcome, and you weigh them by the inverse probability of censoring. And if you do this, you will recover the true outcome probabilities, including in competing risk settings, including when you're trying to predict multiple outcomes. And if you do this well, and we've done this in the paper I'm mentioning here with Julie Alberge, then you can plug this in any solver used in machine learning. So you can adapt almost any machine learning method to this. So it means you can compensate almost any machine learning method for censoring. And you need to do this if you want it to be useful in the case where you have censored data, which is frequent in health. Now, another challenge is when you want to do prediction to support decision, which is something that we want to do very often. And here, for instance, you have an outcome, a health outcome, and you have health covariates, and you're predicting the health outcome from the covariates. And the question you're asking is, can my predictive model orient my intervention choices? And here, what you're going to do is that you're going to model the outcome not only as a function of the health covariates, but also of the intervention of interest. And then what you need to do is that you need to contrast those two outcomes, the predicted outcome had the individuals been treated versus had the individual not been treated. And there's so what we're really doing here is that we're building a machine learning model to extrapolate the outcome across individuals. But there is a challenge. The fundamental challenge is that the healthy individuals did not receive the treatment, and the unhealthy individuals received the treatment. So you can see it here is that I have very few untreated individuals in this part of the curve. And so if I'm not careful with my machine learning model is just going to collapse back down. And so I'm not going to go into details because I lack time and because it's slightly technical. But when you do this, you need to adapt the machine learning models. We've just published a full review on this, but I didn't have time to add it on my slides. So sometimes here, a simpler model is better because it extrapolates better to the part of the data where you don't have data for both outcomes. And there's one more detail is that when you want to use predictors for decision making, you need to be very careful not to put post-intervention information in your predictors, because then they will give you, once again, predictions that are not interpretable as causal predictions and hence not interpretable for decision making. Okay, so we can use prediction to support decision, but we need to be careful with the predictors you use. We need to use tools from causal inference, and we need to be careful with the data that you put in. And so, to zoom out and to conclude, in many cases, the data does not perfectly reflect the application. So it's not a question of best predicting the outcome given the data. I've given you two examples: survival analysis, where the individuals are not observed long enough; causality, where I observe only one potential outcome per individual, and I can have a shift in distribution between the treated and the non-treated. In those cases, more data and bigger learners will not fix the problem, and we need dedicated compensation mechanisms. So machine learning has promises, but often it needs to tackle those challenges. Thank you.